Rama Baru, and I am a professor at the Center of Social Medicine and Community Health, Jawaharlal Nehru University. My journey into public health has been rather diverse and long. For my graduation, I did basic sciences, zoology and botany. And then for my master's, I moved to train as a medical and psychiatric social worker. And in the process got exposed to various both medical and psychiatric contexts, but I was very dissatisfied working in an institutional setup. And so at that time, during the 80s, there was this community health movement, community-based rehabilitation movement for the disabled. So I actually got involved in community-based rehabilitation. So when you work with urban poor for community-based rehabilitation, I think the community and that exposure teaches you many things about the complexities of the relationship between illness, society, between vulnerability, and also that there are many decisions that are made in families that are not, that go beyond the priorities of just treating or taking care of a child who is ill. So I think the experience of both the joy and the frustration, in a sense, of working in those contexts kind of pushed me to understanding that none of these solutions are individualized. You have to have collective systems that respond to needs of people. So therefore, you could do collectives in the communities, but you also needed public systems. So I think these kinds of questions kept sort of cropping up. We also saw limits to our intervention because of that. And at this point in time, I actually got exposed to some of this writing, which today you would call as social determinants in health, which was really looking at politics of health. And in fact, this writing came largely from the Center of Social Medicine by senior professors like Dr. Banerjee and Imrana Khadir. And I didn't know who they were, but I was reading their work. And I was also very clear that I wanted to go out of the social work paradigm, which was, highly individual in its orientation. And I understood the need for collectives. I also understood the gaps and the lacunae in the public health system. So I think that's what attracted me and took me to JNU many years later. And it opened up my world to understanding public health as an extremely, complex area which involved so many different disciplines. And disciplines where you needed to have some idea of biology. You can't run away from biology when you're talking about illness. But it also brought in the need for an interdisciplinary perspective. That if you had a child who had a hearing disability, it would mean that you just don't need that problem to be detected or telling the mother how to handle the child. There were other elements of support, caregiving, education, and also specialist care. For example, if the child needed speech therapy, you don't get that at a primary level. You have to go to a hospital. Now, if a mother is a daily wage laborer, how does she take that one child who is of, say, four, he's one child, what is the kind of time that she has at her disposal to actually take the child? And even if the hearing aids are free, what is the indirect cost that is incurred in transporting and waiting, and it's not a one-time visit. So in a sense, much before the report on Commission for Social Determinants and Health, we had already been oriented to understanding this relationship between socio-economic, cultural, and political factors. And that ultimately health is not just about illness and disease, that it goes much beyond that. And also to say that it's not just physical health, but it is also emotional and mental health. And that neither of these three are inseparable from each other. I think the best example is that if you talk to anybody, including yourself, and ask what is it that determines health? I think they will say doctors initially, maybe. But I think societies and cultures have always seen health as being determined in much more complex ways. And we have, for example, anthropological writings on this. That when you ask people, so what are the factors that influence your health? They will talk about food, they will talk about work, they will talk about wages, they will talk about, clean environment. And even today, if you go to large parts of this country and ask them, why do you think people are unwell? They'll say, oh, all the pesticide in the food. Earlier we used to eat food without pesticides. Even if you interview your grandmother, you would get this kind of a response. So I think at the level of experiencing life, health was a part of living. Health wasn't just a pathology. And therefore you saw those interconnections. And at another level, you saw even health as determined by morality. You saw the relationship between being good, doing good, and also in terms of the, all the various aspects of one's life which you live as human beings was connected to health. Because a very interesting study that was done in Rajasthan by this anthropologist called Carstairs, where he talks about the moral world of understanding illness and disease, where they did talk about, if you indulged in immoral acts, if you cheated on your wife, that also contributes to guilt, and that guilt then acts on your... So, this relationship between the psyche and the soma, which in a sense allopathy and modern medicine completely negates. All other systems of medicine have this very complex understanding of the body, mind and soul. So, I think social determinants and health, the idea of social determinants and health has always been there. But it is really the way you ask the question to people. If they know you're a doctor, you're not going to get an answer which is going to go into these areas. But the relationship between food and health is very well known. And even today in all households, it's very well known. That, very often if you have a stomach upset, it's always interpreted in a layperson sense to say, okay, what kind of food did you eat? Did you sleep well? Did you have too much of hot food, too much of cold food? The imbalance of food. So I think that bit was always there. But to go beyond that, which social determinants brings, is the way society is structured and unequal opportunities that people experience both in health, illness and mortality. That is, why do some people have a higher burden of this while others don't? And I really want to say that it is not a rich-poor divide question. I think we need to understand the importance, which is an important concept that the social determinants and health brings out, is the social gradient. Our societies are not just about the rich and the poor. The gap is not just that. There is a very large middle and a very differentiated middle whose experience in a sense slides on either end of the scale. And so therefore I think this idea of social gradient and graded inequalities that the social determinants and health brings to it is very, very important. I mean, if you look at insurance, for example, as a case, you have targeted insurance for the poor. The rich can buy their insurance. What happens to the middle class? They're also suffering from burden of expenditure. They're also getting driven to taking loans, etc. If you don't have any other forms of insurance covers. So I think we need to start looking at this society a bit with greater complexity than we do. And a lot of the health work prior to SDH, I would say, really looked at it as the rich-poor divide, the rich-poor gap. And even now it suffers from that. But the complexity and the reality of it is, in fact, a graded inequality. I think one thing the NFHS survey's data tried to bring out very clearly is, even though it's not from a social science perspective, adequate, it did bring the issue of inequalities. So stratification both in terms of income, or income quintiles, and in terms of caste and religious groups. Now, I would say that one area in program planning which has been used very significantly is, say, the immunization program, where I think there was a lot of worry of how certain social groups are getting left out. And pulse polio exemplifies that. So you use data in order to move this forward. I would say some of these national programs, fertility control is another one, where you were trying to identify social groups where you felt that, was not adequately reducing in their fertility levels compared to other groups. But what it does not capture, the NFHS data, is SC as a constitutional category or an ST as a constitutional category does not capture regional specificities. So is a Dalit in the lowest jati in Tamil Nadu the same as the one in Bihar? Now, what is the historical difference in the experience of these two? So they're both SC, but their material conditions are very different. Their health chances are very different. So I think those nuances we are not able to capture. If you read the SDH report carefully, many countries have adopted what they call as, and especially South Africa was one of the leaders, what they call as the equity gauge. They actually institutionalized something called the equity gauge. And that was part of this policy after apartheid to look at what was happening to racial differences in relation to health outcomes. I mean, you can do it not just for health, but you could do it for education, employment, you could do it for various things. And because they set up the equity gauge, they also it drove for the data to be collected, for them to track over time what was happening to this gap. Was it reducing? Was it increasing? Where was it increasing? Why? So I presume if you have that kind of a interest in your planning exercise, that you want to reduce inequalities, and there have been international pressures, let's not get away from that how has inequality even come into the Indian agenda in a sense? Your funding agencies have pushed for it. A number of them have given riders, the MDG being one very good example of that, saying that the Human Development Report, where you may be a high growth economy, but you perform so poorly on all social indices. So I think those have been also ways in which India has been pushed to at least speak the language of the importance of inequalities. I always tell my students that public health has got a particular problem. The particular problem is that we tend to separate the academics from the action. That is, very often we are asked as public health professionals, so okay, now give us 3 things that you want to do which will set this problem right. The moment you say it's far more complex than that, then policymakers and even others tend to shut down. I think the part of the problem is that management science has redefined public health in a particular way. So it tends to negate any difficult questions from being asked. But public health, if you don't ask difficult questions, then how will you find solutions? And I think there is this inherent tension now in public health. Having said that, I will say it's very important for public health scholars to read, and to read very widely, because I remember a feminist, Betsy Hartman, who works on population issues, telling me that in the 70s we were activists, we were also academics, but we engaged with the science. What is increasingly happening in the world of public health is that we are so solution oriented, we are neither engaging with science, questioning that science, nor are we engaging with social sciences. or you're engaging with social sciences of a particular kind, which reduces to say, let's do more of behavioral change. It individuates solutions. And I don't think if you're in public health, you can ever individuate solutions. I would really say that even if you're a practitioner of public health, you have to read. And I really worry because increasingly, you see, NGOs also claim they do research. NGOs also claim that they are much more engaged in policy for reasons. I think in the last 20 years, the NGOization of public health has been fairly complete. They have stopped reading. They don't engage with just reading on the science, reading on the social science, dealing with complications. They kind of get caught in this dizzy world of, we are making a huge difference. And if you don't read, then you won't know where you're located and what are the limitations of what you do and where you may have to stop and think and move in another way.